Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers, and the question last week was: my mum is in ICU with respiratory failure. Why does the ICU team refuse to treat her any further? Is this fair? You can check out last week's question by clicking on the link below this video. In today's episode of Your Questions Answered, I want to answer a question that we get quite frequently from our readers as part of my one-on-one consulting and advocacy service. So today's question is: how many patients die in intensive care or in ICU? So let's look at this in more detail. Mortality rates in ICU or intensive care strongly depend on the severity of illness and the patient population analyzed. Admissions in ICU vary in different countries. More than 5 million patients are admitted annually in the United States, while there are 230,000 adult ICU admissions in Canada. An estimate of between 10 and 15,000 critically ill adult patients require critical care in ICUs each year in Ireland. ICU admissions each year in the United Kingdom have been around 270,000, with 160,000 patients admitted to intensive care units in Australia, and New Zealand and Germany ranks around 1.9 million ICU admissions annually. The average mortality rate reported in the United States ranges from 8 to 19%, or 500,000 deaths annually approximately. Again, that's around 10% in the United States. Acute care separations that ended in death accounted only for 10% in Australia and New Zealand. ICU deaths occurring in Canada comprise around 29.2% for one fiscal year, while there was an estimated 16,424 ICU mortality for the United Kingdom for the most recent year published, 2015-2016. So we've also inserted a table for those numbers that I just shared below this video in the written version of this blog. And if you're watching this on YouTube, just click on the link below this video. That'll get you to our website where you can read today's one-on-one question answered, and where you can also have access to the tables that we publish and also to the references. Moving on, one research study from Canada: hospital beds and adult ICU beds per 100,000 population internationally showed an overall unadjusted ICU mortality of 9% in Canada. Internationally, there is a wide variation in mortality rates from 6% in Germany and 10% in the US to 29% in the UK. There are different types of ICUs that provide care to specific patient populations, categorized as general ICUs, which provide care to patients who require intensive care for common medical and surgical reasons. Next, specialized ICUs, for example, burns, cardiac, neurosurgery, trauma, respiratory, provide care to meet the needs of a specific type of illness or surgery or injury. And pediatric and neonatal ICUs provide intensive care to children and newborns or neonates. So let's look at what are the reasons for admissions to ICU or intensive care. Well, number one is to invasively or intensive monitor patients. Next, support of airway, breathing, or circulation. Stabilization of acute or life-threatening medical problems. Comprehensive management of injury or illness. Restoration to stable health status or comfort while dying with an interdisciplinary and collaborative environment. The intensive care units or ICUs are part of the hospitals where care is provided to the sickest patients. It is typified by having a high level of monitoring and therapeutic technologies, a very high degree of organization, and high staff to patient ratios. Most ICUs have a 1-to-1 nurse to patient ratio. Despite the high severity of illness of patients admitted to ICU, most improve to the point to be discharged to a normal hospital ward care environment. A significant proportion of these ICU discharged patients subsequently die in the hospital, with post-ICU mortality rates ranging from 6 to 27%, either as a result of residual organ dysfunction or failure, or due to the inability of the staff in lower levels of care to cope appropriately with the needs of the patients. Although patients in intensive care units receive care for a large variety of disease states, the leading causes of death in ICU are: number 1, cardiovascular failure. Cardiovascular system failure is commonly faced by the intensivist. Heart failure can occur due to a host of predisposing cardiac disorders or as secondary effects of systemic illnesses. When the heart is unable to provide an adequate cardiac output to maintain adequate tissue perfusion, cardiogenic shock happens. Without prompt diagnosis and appropriate management, these patients have significant morbidity and mortality rates, with in-hospital mortality approaching 60% for all age groups. So what is, for example, a cardiogenic shock? Cardiogenic shock is a condition in which your heart suddenly can't pump enough blood to meet your body's needs. The condition is most often caused by a severe heart attack, but not everyone who has a heart attack has cardiogenic shock. Cardiogenic shock is rare, but it's often fatal if not treated immediately. If treated immediately, about half of the people who develop the condition survive. So let's look at cardiogenic shock signs and symptoms. Number 1, rapid breathing. Severe shortness of breath, sudden rapid heartbeat, also known as tachycardia, loss of consciousness, weak pulse, low blood pressure, also known as hypotension, sweating, pale skin, cold hands or feet, urinating less than normal or not at all, also known as kidney or renal failure. Let's look at the symptoms of a heart attack. Because cardiogenic shock usually occurs in people who are having a severe heart attack, it's important to know the signs and symptoms of a heart attack. These include pressure, fullness or a squeezing pain in the center of your chest that lasts for more than a few minutes, pain extending to your shoulder, one or both arms, back, or even to your teeth and jaw, increasing episodes of chest pain, shortness of breath, sweating, lightheadedness or sudden dizziness, nausea and vomiting. Let's now look at multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome, also known as MODS or MODS, is a continuum with incremental degrees of physiological derangements in individual organs. It is a process rather than a single event. Alteration in organ function can vary wildly from a mild degree of organ dysfunction to completely irreversible organ failure. The degree of organ dysfunction has a major clinical impact. In a classic 1975 editorial by Bowe, the concept of multiple progressive or sequential system failure was formulated as the basis of a new clinical syndrome. Several different terms were proposed thereafter, e.g. multiple organ failure, multiple system organ failure, and multiple organ system failure, to describe this evolving clinical syndrome of otherwise unexplained progressive physiological failure of several interdependent organ systems. Eventually, the term MODS or MODS was proposed as a more appropriate description. MODS is defined as a clinical syndrome characterized by the development of progressive and potentially reversible physiologic dysfunction in two or more organs or organ systems that is induced by a variety of acute insults, including sepsis. Next, central nervous system failure, also known as CNS failure. CNS failure represents a spectrum of disease ranging from mild neurological impairment that may have motor, sensory, visual, speech, cognitive manifestations or a combination thereof, to comatose states and brain death. Common causes of central nervous system failure: anoxic brain injury, traumatic brain injury, ischemic stroke, spontaneous intracerebral hemorrhage, metabolic infectious derangements, liver failure, renal failure, diabetic ketoacidosis, also known as DKA, meningitis. A sudden acute nervous system problem can cause many different symptoms depending on the area of the nervous system involved. Stroke and transient ischemic attack, also known as TIA, are common examples of acute problems. You may experience the sudden onset of one or more symptoms such as numbness, tingling, weakness, or inability to move a part or all of one side of the body, also known as paralysis. Dimness, blurring, double vision or loss of vision in one or both eyes. Loss of speech, trouble talking or trouble understanding speech. Sudden severe headache. Dizziness, unsteadiness, or the inability to stand or walk, especially if other symptoms are present. Confusion or a change in level of consciousness or behavior. Severe nausea or vomiting. So now that we've looked at the mortality rates in percent and also in numbers, and now that we've looked at the causes, major causes that lead to a high mortality rate, let's look at what the outcomes are. And the outcomes are, after being admitted in ICU, are very difficult to predict. And most ICU doctors know patients among all the thousands who did recover against all the odds. And I certainly know of many patients that recovered against all the odds after having looked after thousands of critically ill patients in intensive care, after 20 years of working as an intensive care nurse in ICU in 3 different countries. So the ICU team is there to save lives, and by all means prolong life. In reality, yes, odds are in a patient's favor according to the statistics. There are massive numbers of ICU patients who survived, and let your loved one be part of the overwhelming majority of ICU patients who made it through. Allowing death in ICU or in intensive care, even when there is still uncertainty about the outcome for the patient, can be straightforward, but you can be powerful advocates for keeping your loved one alive, even when doctors and nurses think otherwise. Take into account what the patient themselves would have wanted, and that is valuing the chance of life at any cost. So how can you achieve that? And how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power, and influence quickly, whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care, and how your critically ill loved one's treatment may depend on those competing interests, how to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind the scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site, intensivecaresupport.org, for families of critically ill patients in intensive care. You can also call me, find phone numbers on the top of the website. Also, have a look at our ebook section, and you can also get one-on-one consulting and advocacy with me over the phone, via Skype, and via email by clicking on the relevant tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.